All right, so it is June 6th. Oh, look, I got that on the actual review session. June 6th. It's about 10 o'clock in the morning on June 6th. I'm actually back in Las Vegas. I'm very happy. I'm no longer broadcasting from a hotel room. So that makes me very happy. And I actually have my setup, and I have my computer, and I have internet that's not crappy. So I'm very happy to be back. So the topics that were requested today, we had actually a bunch, 3 or 4 people request special tests. So we'll talk about that. 2 people requested pediatric reflexes, 3 people requested brachial plexus, and then somebody added at the last second, can you add hand injuries to brachial plexus, which I understand how that kind of works. So we're going to go through this as we go. So special tests. What do you need to know about special tests? Well, a lot of what you have to know is you have to remember the spin and snout rule. I'm going to tell you, this is going to come back. I can guarantee it, as they would say in Louisiana. I guarantee these are going to come back to you. So these are determining how effective a test is. And by effective, I mean, does it work? Does it test what it's supposed to? So spin and snout. Remember that a specific test, so a test with high specificity. So let's write one up here. You'll see this on a lot of the tests. It'll say SP 0.87, SN 0.65. And I'll write another one up here. SP equals 0.33, SN 0.91. So you'll see that a lot of times on tests. And actually, I was looking at the some data on whether or not we might need booster shots for the COVID vaccine, and looking at the specificity and sensitivity of the tests that they're running for that. And they're actually, like, not the booster shots, that's not what I'm talking about. The tests they're doing to test for COVID antibodies and stuff like that have a really high specificity. Like the one test I was looking at, the specificity was 0.97 and the sensitivity was 0.94. That's a really good test, right? So a specific test, a test with a high specificity, when you get a positive result. So let's say we're testing for shoulder impingement and you do the empty can test. And you get a positive result, meaning the patient lifts up their arm and it hurts. That's a positive result. That means it rules the condition in, meaning the patient probably has that condition. So supraspinatus impingement or whatever we're testing for. So that's why I remember SPPIN, spin for specific. A sensitive test, so one that has SN. Well, that's supposed to be SN. Good job, Mr. McKeever. SN, right? A sensitive test when it gets a negative result, meaning, again, I'm doing that empty can test and I'm like, no pain the whole way through it. That would be a negative result. I didn't get the pain elicited. If it's negative, it rules it out, meaning that's not the problem. So looking at these 2 tests up here in the upper right, this first test has a pretty high specificity. It's 0.87. Ideally, you'd want it definitely over like 0.7, 0.75. And what this means, 0.87, it means if you tested 100 people and you use this test, if 100 of them came back positive, 87 of those 100 would definitely have the condition. That means it's got a pretty high specificity rate. Sensitivity, on the other hand, is, again, ruling something out. So this one has a 0.65 sensitivity. So if we use this test and we got a negative, we wouldn't really know if the patient was not having the condition or if they do have the condition. That's one where we go, maybe, maybe not. We might want a second test like this one down here to definitely rule out the condition. So in this case, the second test here, the specificity sucks. 0.33, that's garbage. But the sensitivity is really, really high, meaning if they're negative, we definitely can rule that condition out for the patient. Ideally, what you want is something to test like this. I mean, this is like the gold standard. This is one that has high specificity and sensitivity. What that means is whether you get a positive or a negative, you can pretty much make an assumption about what you're getting from the patient. So something like the Thomas test would be a pretty good example of this. The Thomas test is the one where you lay back, you pull your knee to your chest, and if that other leg comes up when you lay back, that means you have tight quads. That has a pretty high specificity and sensitivity, meaning if my leg doesn't come up, you're pretty good at ruling out and saying the patient doesn't have tight quads. But if my leg does come up, I probably do have tight quads. So what are the common tests you might get asked about? Thomas is probably one of the big ones. Over, where you test the leg over the other. Anterior posterior drawer, along with Lockman's and SAG tests. Nears, Adson's, and the empty can test. Those are the majority of the ones I have seen on the boards. Now, does that mean you might get a question about let me think of one that's kind of obscure. The Scour test. There's a real obscure test, the Scour test, right? You may get a question on the Scour test, but it's going to relate back to this, spin and snout. So it will say something about, the Scour test, you're testing a patient with the Scour test, a test for labral impingement. And it has a specificity of 0.97 and a sensitivity of 0.33. You get a negative result. What can you, so let's actually write that out, because that would be a good kind of test question. As soon as I said, I'm like, that'd be a good question. So you are testing a patient with the Scour test. Okay, so this would be a question that would look like something on your boards if it's kind of an obscure test. So you're testing a patient with the Scour test to determine if the patient has labral impingement. The specificity is 0.87, sensitivity is 0.33, and you get a negative test. What can you deduct from this result? So it would be patient has labral impingement. The patient does not have labral. So that would be what the question would look like. Let's make this a different color so it shows up on the screen here. Let's make it yellow. There we go. So you're testing a patient with the Scour test, determining if the patient has labral impingement. It says specificity is 0.87, the sensitivity is 0.33. You get a negative result. What can you deduct from this result? So which of those, so first of all, which of those can you rule out right away? Okay, Dylan's saying A. Okay, good. A and C, right? Because C has nothing to do with it. C is just one of those questions that's there to confuse Clarice. Clarice is like, well, wait, they're talking about labor. Why is it saying ACL? That's all that's there for. That's a red herring. It's to get you thinking about something else that you shouldn't be thinking of. So Dylan says A and C are out. So let's trust Dylan here and say we're going to rule A and C out. So that takes us down to B and D, right? So because this sensitivity is very low, does that mean this negative test means anything? I know you guys aren't awake yet. Not really. Good. So that means your best answer is D. You need to do additional testing. Right? So maybe there's an additional test you can do. And unfortunately for labral impingement, there's not. You could do imaging would be the best at that point. That would be additional testing. There's not another kind of, and for those of you that don't know the Scour test, you kind of bring the hip up into hip flexion. You put pressure down on the kneecap and you literally grind the femoral head in the acetabulum. I'm going to be honest, most of the patients I've done that with, they don't feel comfortable doing it and it hurts them. So like I always get a positive test from that test. I don't know why we even have it, to be 100% honest. But does that make sense? So in the case of a sensitive test that doesn't have a very valid result, so it doesn't have a 0.75 or better, it doesn't tell us anything. Now, what if I change this and said you get a positive result? Does that change things? Yes. Right now, what does that become? Which answer does that become? Props to A. Yeah. Right. Good. Because 0.87 is a really good specificity. So that's saying, yep, this patient does definitely have labral impingement. So let's look at some tests going down through here. So this is, I think this is out of therapy ed, or it might be out of Scour Builders. I don't remember. They have all these special tests in here that are in there. The main ones, like I said, I want to hit are these here. So let's just quickly hit them. Thomas test for what? What does the Thomas test for? Yeah, hip flexors, right? Hip, flexor, tightness. Good. What about the over test? IT band. Good, right? Tightness. That's the one where you drop the leg over the other. That's why I always remember that one. It drops the leg over the other leg. And as the leg falls into adduction, the abductors get stretched way out and they'll know if they have pain. So the anterior drawer tests for what? Yeah, ACL, good. Posterior is PCL, I saw that already, right? So what about the Lockmans and the SAG? Which one of those tests for ACL?
Lockman?
Lockman's test is for ACL. Good, right? And think about SAG. SAG is exactly like it sounds. You're going to put the leg in a position where the leg kind of sags backwards. If it's drifting backwards, it's testing for what? PCL. Good. Yeah. Right? So when I look at these, the SAG kind of goes with posterior drawer. The Lockman's kind of goes with the anterior drawer. And for most of them, the difference is the amount of angle at the knee. So like Lockman specifically, I think requires 45 degrees. But to be dead honest, they're not all that different. I think Lockman's has a higher specificity, if I remember correctly, than the true anterior drawer test, but they're testing for that. What about NIRS? What is NIRS testing for? It's okay to look up if you need to. Okay, shoulder, good. We're going to the shoulder. But shoulder what? Oh, let's look forward here, Mr. McKeever. Bet it's somewhere in here, huh? Let's see. Jerk test, horizontal, blah, blah, blah. Maybe NIRS isn't. NIRS isn't. How about that? What is NIRS testing for?
Shoulder flexion?
I can't hear. Shoulder what?
Is it shoulder flexion or something?
Yeah, so it's tested. Yeah, it's testing. It's another kind of rotator cuff shoulder impingement test. Right? What about Adsons? You guys know that one. I know you covered that with Dr. Reskin in the shoulder class. And I talked about it briefly. How about I give you a letter? We're going to play hangman. It's 3 letters. Thoracic outlet. There we go. Good. TOS. Thoracic outlet syndrome. Mute my iPad. And then empty can is another shoulder impingement. We actually already just did that. A lot of the tests test the same thing. Why is that? Because of that specificity and sensitivity problem. There could eventually be, for all we know, there could be a FAR test for rotator cuff tears. Dylan could come up with his own test someday, and we may all be using it. As long as he researched it and, you know, took it pretty far. Right? So there can always be a test that you guys can design. So when I'm looking at these, and when I was studying for this, because this was my concern too, because there just seemed like there were so many freaking tests. The list that the book shows are the more common ones. Okay, so even the hand tests like the Phalens and the Tonells. But what I'm really focused on when I'm looking at the test is making sure I understand the spin and snout rule and understanding what's going on when I am testing the test. So there's nearest positive internal rotation, right? There are pictures that go along with it. Are you guys going to have to know every single test on the boards? No. Average number of questions for special tests is about 3 per test, if you get any. I know that I talked to 2 students that said they didn't get a single special test question on their boards. So that kind of surprised me because usually those are about 3 per test. Most of the times, I'm going to be 100% honest, most of the times, the ones that people got were anterior posterior drawer and Thomas. So know those tests. These tests here are the tests. If I had to break it down and make you guys forced to study them, those are the tests I would tell you to study hard. I try to distill it down to as short of a list as possible. Does that mean if you have extra time in the future that you don't want to go back and look at, let's see, what are some other random ones here? The sulcus sign. No, if you have time, but focus your testing on, or testing prep on stuff that is more likely. They're going to be asking, yeah, great question. So let me answer that question, answer in a second. So they're going to be, make sure you're focusing on stuff that is more likely to come up on the test than, you know, less likely. So Dylan asked, would they ask how to perform it or just what they're testing? Usually either just what they're testing or that specificity and sensitivity. Those are what they're asking. They're not going to say, you put the patient in passive flexion at 85 degrees. Is that enough for Hawkins-Kennedy? No, that's not what they're going to ask. They're going to ask more kind of what the Hawkins-Kennedy is testing for. And I don't know if you guys remember, but in Therex 1, I gave you a like 10-page sheet of all of the special tests that exist. Like every single one under the sun. And if you don't have that, I can repost that. It was like, it just had all this, and it had all the specificity and sensitivity, not that you have to memorize those because they'll give you those on the board. So don't freak out yet. You do not have to memorize the specificity and sensitivity of the test. I'm going to say that again. You do not have to memorize the specificity and sensitivity of the tests. They will give you them if they are going to ask you a question about it. So they will say the test is specificity 0.32, sensitivity 0.89. So you don't have to memorize that. Does that make these things seem a little bit better at least then? Again, main idea is what they test for and if you can understand specificity and sensitivity. That's really what the main point of special tests are. I don't know why that's still in there. Ignore that. Sorry. Pediatric reflexes. There are so many reflexes, right? You guys, all this, right? And there are so many dates that vary on these pediatric reflexes. So how do I know it's right? The best idea with pediatric reflexes is to categorize your reflexes. So I'm going to look at one here. So the gallant reflex, right? So this is where you touch one side of the spine. And you should see a lateral flexion to the side of the stimulus. So you come towards the stimulus, right? The book says it should integrate within 20 weeks of gestation to 2 months after birth. If you're looking at that, that's a pretty big range. What I look at that and go is, okay, I need to know that by 2 months, the gallant reflex needs to be integrated. Because what the question is going to ask you is, you have a child that is 24 months and gallant is not integrated. Is this normal or abnormal? That would be abnormal. So what there may be, or they may say that, you know, what time is normal for a child to integrate the gallant reflex? And they're going to give you like 24 months, 36 months, 2 months, 18 months, and 2 months would be the better answer there. So it has to be integrated by 2 months in order to get normal function, right? They're not going to give you questions where the months are like super close. So it's not going to be like 2 months, 3 months, 5 months. It's going to be pretty clear what the answer is. Your job is to know whether the test or the pediatric reflex response is normal or abnormal, right? Or what is needed for and when the months don't matter at that point, right? This is where you read the flexion. Again, the gallant reflex is critical to the development of balance and leads directly to scoliosis. So it may ask you a question like, gallant is responsible for helping a child first achieve proper balance righting. Because again, it's stimulus to the one side causes a lateral flexion that side. We do that when we start losing balance, right? We get a stimulus and we kind of go to that side. That's what you have to know. I find this chart is probably the most helpful to me. I actually have this chart on my clipboard when I'm working in pediatrics because even myself, I don't remember all of the pediatric reflexes. Even when I teach this or I tutor on this, I have to review pediatric reflexes like crazy.
There's actually like a paper that Dr. Breskin gave to us.
That was my next comment. Was that Dr. Breskin's paper is another great resource. Yeah, I think she made it pink.
It's like helping me right now.
Good. Yeah, I think it's pink or orange. I forget what color she made it this year or this time. Right? That is another great resource. But again, even that has like a range of months, right? It's not exactly this month. One of my favorite ones to use is the Babinski reflex, right? So if you had and the question might be something like this. So let me get annotations up here. I want to go back a page so that I have a little bit of room to write. You would get a question like this about Babinski. Oh, color mine. Yellow. Let's go with red. Red looks like a good color. Which of the following patients would, of which of the following, there we go. How about this? Of which of the following patients would a positive Babinski abnormal? So what we're looking for is which of the following patients is Babinski abnormal, meaning it's not, shouldn't be there. So A, child 8 months. B, there's your question. So which of those would a Babinski reflex be abnormal with? I know this one's a tough one because that upper motor neuron injury threw one in there on you. I know it. B, right? Because when is the maximum time it should be integrated by? Does anyone know? Babinski has to be integrated by 2 years, so 24 months. So at 36 months, a child with a positive Babinski is definitely out. If I'm looking at this question, it normally integrates by 12 months, Clarice, but it has to be integrated by 24. Does that make sense? Because by 24 months, what should the child be doing? Walking. Yeah. So there's a normal integration period, and then there's once you're outside of this range, it's abnormal integration period. So usually the books, and they vary, a lot of the psychology books say Babinski should be integrated by 6 to 12 months, but 24 is abnormal, and that's what a lot of the physical therapy books say too, is that at 24 months, if it is not integrated, something is wrong with baby. And usually, what do you think the condition that might cause a baby to have a non-integrated Babinski? What would be a brain injury for baby?
ALS.
Okay, well, ALS, but that's a little early for that to set in. What's the common brain injury that babies get? Or the common condition that has brain damage? CP, cerebral palsy. Right? Because remember, CP is not a problem with the limbs, even though it looks like it's a problem with the limbs. The brain is broken because of what? What did the baby lose during birth, typically?
Cerebral.
Yeah, cerebral, good, right? They lost oxygen. They had an anoxic event. Usually because they came out and umbilical cord was wrapped around their throat, or for whatever reason, they had a stroke during birth. That leads to CP. So yeah, definitely the child with.
So anything like pretty much 24 months is still kind of like considered normal?
Yeah, anything up to 24 months, it means it can integrate and become normal.
Become normal. But anything after 24 months, that's abnormal.
That's bad.
All right.
Yeah. Right. And usually, and honestly, because I've dealt with these kids before, at 24 months, if it hasn't integrated, they're walking on their tippy toes, like literally like dancer tippy toes type stuff, because Babinski, every time they put their foot down, their toes kind of flare back and they end up on their tippy toes. So yeah. So when I'm looking at these, like the different ones that are out there, the major ones I'm looking at for baby and normal development, these two are really important. ATNR, STNR. You should know ATNR and STNR like the back of your hand. If I'm going, okay, there are two that I definitely need to know. Those are the two that you definitely need to know. Symmetrical tonic neck reflex and asymmetrical tonic neck reflex. If you look, STNR integrates later than ATNR. So that means that one's a little bit longer to develop. Moro is also kind of important, but the other one I don't see here, is rooting. And that's because usually rooting is one that's common. And the main thing you need to know about rooting reflex is what happens if rooting reflex doesn't integrate. What is rooting reflex? Yeah, feeding problems, exactly, which usually leads to malnutrition of baby, which can lead to a whole host of other problems, right? Rooting is the baby where you stroke their cheek and they turn towards it for feeding, right? That's the mommy reflex is what I call it, because that also leads to bonding of mother and child, right? For those of you that have had children, and I'm not questioning if you breastfed or not, but there is a certain bonding of child that happens with you. If the child doesn't turn to you when they're kind of being held by you, that kind of messes up the bonding of mom and child, and that can lead to emotional problems down the line too. Also, over breastfeeding children can sometimes cause that as well, but that's beside the point. We're not going to talk about that today. Today is not a psychological class. So the labyrinth reflexes, the main thing I look at those, so we've got tonic, labyrinth, and then labyrinth head, right? When I'm looking at those, anytime I see labyrinth, I'm thinking what? More than anything, I'm thinking of balance, because we know labyrinth is dealing with the inner ear. And most of those are protective reflexes, meaning they are there to help you keep from having problems. Out of all the stuff that was the hardest for me to study going into this boards was this stuff down here. Normal baby development.
It is officially 6:30.
Oh, hold on a second. I don't know why suddenly my computer decided to start playing another lecture. Give me 1 second. There we go. I don't know why I did that. Thanks, computer. You're welcome. My computer sometimes talks to me. So development. The main thing you need to know with development is the process of getting to walk, right? Meaning, how does a baby start walking? So what's the first thing they start doing? What's the first thing to start the process of walking? They have to get from their back to their belly. So that's what? Rolling. So once I've gone from back to belly, right? So I've got rolling. What's the next step baby starts to moving around? They start doing one of these.
Crawling.
Right. So first, yeah, so we start crawling, which is typically what type of movement? It's on the belly, right? They kind of start pulling themselves along. So I like to think they start going to army crawl, right? And then the next step is quadruped. That's a P. Because quadruped gets them up onto all fours. Now, once I'm up on all fours, now I can start motivating, right? And those of you that had parents, this is the point where it started getting scary for the kid, I think. Because army crawl, you can catch the kid. Sometimes those kids, once they get up on quadruped and start walking on all fours, man, they can motivate around a room. Right? So they get up on all fours, then they start, what's that term for walking on all fours?
Jervin said his internet crashed.
Okay, that's fine. I'm recording it for him anyway. Thank you. What's it called when they start walking on all fours? Because it also leads to going along furniture. Also starts with a CR. Yeah, there we go. Creeping. Right? Then they start pulling themselves up, right? They pull upright. And most of the time, that's on furniture. For those of you that are parents, you've seen that, right? The first thing that happened with a child when they were able to, they either pulled themselves upright on you or they found some furniture and pulled themselves upright. And once they got themselves upright, they realized, I can use this to move around, right? And they start going along the furniture. And then once they do that, then they move to walking. So it's as important to know the dates. I mean, the dates are important for that, but really kind of knowing that process of developing it is important. And it's funny because we're actually looking at this in stroke research now, that patients that have problems with walking, if we take them back to pediatric development and start them with, crawling, creeping, and then walking, we're actually finding they get back to walking faster. Although telling an old person to crawl on the ground is like, right. Michelle, that's cool to me too, because what that says is there's latent pathways there that even with a stroke or something happening to the brain, TBI, we can use those latent pathways, right? Isn't that kind of neat to me? I mean, that's hugely neat to me. That's that whole, neuroplasticity idea. So with babies, they're not going to ask you when do they first start developing fine motor movement that they can manipulate small objects. That's not one. That's more of an OT question. Our job with babies is going to be gross motor movement, the reflexes when they should be integrated with, or when they should be integrated by. And then also the other big one I notice with babies you'll get questions on is Rhineck, right? Or torticollis. That's that tightening of the SCM. Again, how many questions on pediatric reflexes? Probably one. Now, granted, I know you're all like, well, that one could make me fail the test, Mr. McKeever. Right. But so could the 9 questions about Parkinson's. So if I'm a betting person, I'm making sure I understand Parkinson's more than I understand pediatric reflexes. I'm not saying that they're not important. I'm just saying that probably Parkinson's and MS are more important than pediatric reflexes. So you've got to make sure you're hitting those things in appropriate levels. All right, brachial plexus. I covered this in depth because I thought this was covered more in your patho class, but evidently it wasn't covered as much in depth as it was because I talked to one of the people that actually asked this. And evidently you guys didn't learn too much about brachial plexus. Is that correct in patho? I mean, when I talk about damage to the brachial plexus, more than just you learned brachial plexus from Dr. Johnson. So the brachial plexus, right? Nerves that carry movement and sensory signals from the spinal cord out to the hands. Good. Brachial plexus injuries usually stem from trauma to the neck. More often than times, the trauma occurs near or at the time of birth. The brachial plexus injuries often heal well if they aren't severe. Many people with brachial plexus injuries recover 90 to 100% of their normal function of their arms. So good news. But sometimes in more severe cases, surgery may be needed. So if you've had an injury to that brachial plexus, you really should call for somebody to help. That's the main thing, is if somebody's had that, they should be seeing us, right? That's the main idea of brachial plexus injuries. So looking at the brachial plexus itself, right? It ends in 5 major nerve branches. We end up with MSC or musculaneous, right? About C5, C7, but it does get a little branch from some other stuff. It flexes the muscles in the upper arm, right? The main idea of musculocutaneous is affecting the biceps. It also does the anterior muscular cutaneous nerve, which covers the sensory portion of the front part of the arm. Your axillary nerve, right, lifts the body away. It's the one that helps with this. Median nerve, which we know where the median nerve goes, right? Right there. The radial nerve, our wrist nerve, and the ulnar nerve, the lateral portion of the hand nerve. So this is kind of that brachial plexus. Are you going to have to draw the brachial plexus on your boards? No, there's no drawing. So be happy about that. But you do need to understand, again, going back to dermatomes and myotomes, where those nerves get their, get their roots from. So where does musculaneous? Now, musculaneous does get some branches from all the way down to T1 if you look at it, right? Because when you look at the brachial plexus, out here we have the nerve roots, right? Here we have that trunks. Here we have some divisions, cords, and then leading to the branches or the nerves. If you look, T1 jumps up here, which would jump up here, which means musculaneous has a small amount of innervation from T1. Very small, but small amount. Well, what could that lead to? Well, what if I have a really bad injury of C5, C6, but, you know, for example, I've got a spinal cord injury or something like that that's incomplete. But for whatever reason, I'm still getting a weird contraction of the biceps. Well, that could be because the biceps is receiving information from another nerve or another nerve root. So the body is designed specifically, especially with the arms, because we need them to live, basically, feed ourselves. That if one nerve gets damaged, another can help with that. That's the whole idea of the plexes. So that's kind of the main. I always remember this as Mamru or Marmu. I forget how Dr. Johnson teaches it, but as long as you kind of remember Marmu, thank you. There's the way he teaches it. As long as you kind of remember that your nerves are out there and they stem from this. I'm more important to remember that muscutaneous is primarily, C5, C6, right? Axillary radial is primarily C7. Median pretty much gets some information from everywhere, right? That's why if we have a thoracic outlet syndrome, a lot of times it mimics carpal tunnel syndrome. And then ulnar is out here at C8T1. So more importantly, what kind of conditions can develop because of it? Well, we can end up with a condition called neuropraxia. Neuropraxia is a stretch. This is the nerve where the nerves are stretched to the point of injury. It can either occur via compression, meaning the nerves are squished, or pulled apart. So with baby, when are they likely to get a neuropraxic incident on that brachial plexus?
Coming out.
Yeah, coming out, right? So when doctor grabs a hold of baby and for whatever reason their shoulders get, especially when their shoulders get caught in the womb coming out, or the doctor, instead of getting a hold of baby to pull baby out, gets a hold of arm and pulls on arm, which they're trained to do, not to do, but sometimes, unfortunately, it happens. Sometimes it's the only way to get the baby out. A lot of times these are burners or stingers is what a lot of the non-nomenclature kind of goes by. If you have a stretch or an overall increased compression, which are neuropraxic events, most of those will heal naturally because the damage is just that they were stretched a little too far. So if you let them rest, most of the time those will return to normal. Excuse me. Ruptures are the problem. In a rupture, things pull off. And you can pull off just a part of the brachial plexus, or you can rip off the whole brachial plexus. How this will affect things is depending upon the location of the rupture, right? It can be repaired with surgery to an extent. We're still not that great at repairing nerves. You know, when we actually get better at that, this will prevent a lot of these injuries. A neuroma can occur on the brachial plexus, but it can also occur anywhere else in the body, right? Does anyone know a common area you hear of a neuroma developing? You may have seen this when you're studying. Morton's neuroma. Did any of you encounter that while you were studying? No one's going to admit to it. I'm like, no, I don't even know what that is, Mr. McKeever. Negative? Okay, so at least I got a negative somewhere. We talked about this when we were talking about the foot back in kinesiology. Morton's neuroma is a neuroma that typically happens between the first and second toes. So big toe and the second toe. And if you take and you pinch down between that, and it doesn't take a lot, it just takes a little bit of pressure. Like I have one in my right foot, but I don't have one in my left foot. You pinch down between there, basically there's a little bundle or a neurovascular bundle that occurs on the nerves, the scar tissue, and it creates increased pain. It's a painful knot, right? So this can happen. There can be surgical removements of Morton's neuroma if they're bad enough, or they can cap off the nerve. They can do ablations on the nerve, which is where they burn things off of them, right? But understand that if they have a neuroma, it's usually they've had a stretch or a tear, and then something kind of repairs itself, but the scar tissue kind of grows up and allows pressure to form on that nerve. And they may need to clean it out, or in the case of me, with the one I've got between my toes, it's not that bad unless you squeeze down on it, or if I have a really, really bad case of irritated foot from running or something like that, then it kind of flares a little bit, but it's not enough for me to go get surgery on it. Brachial neuritis, also known as Parsonage-Turner syndrome, is just a flaring up of the brachial plexus. So could be, related to autoimmune response, could be infections. We actually had a patient once that came into the clinic at one of the clinics I worked at here in town that had a really bad case of brachial neuritis. And it was caused by our good old friend, herpes simplex 1. Every time she had a herpes simplex outbreak, because she had HS1, she had actually a really rampant case of HS1. Every time she had a rampant outbreak of HS1, she should get cold sores. She'd also lose a lot of use of her right arm because the infection would actually infect that nerve branch, that brachial plexus. Autoimmune disease also can cause it. Somebody's got lupus or rheumatoid arthritis, it can cause a brachial neuritis as well. And then avulsion is the worst, because avulsion is where at the nerve root, it's going to be separated from the spinal cord. That's bad. Right? That's where the nerves completely get pulled off the spinal cord. If that happens, there's not a good chance of repairing it, because again, we're not that great at fixing nerve injuries yet. So at birth, in babies, the brachial plexus nerves in the shoulder are vulnerable during birth. Injury to the plexus is common, occurring about 2 bursts for every 1,000 or about 1 for every 500. Larger babies are more at risk for this, or mothers that have diabetes as well. And there's some link to that because of the mothers typically have some obesity and stuff like that. In the books, when I was taking some of my pediatric classes, they said that a child that is typically over, especially over 8.5 to 9 pounds is typically very likely to develop an injury during birth. And that kind of makes sense, right? I mean, those of you that are mothers, I think, Michelle and Sukane, I think, are my 2 mothers in here. Imagine giving birth to a baby that's like 13 pounds. There's not a lot of space for baby, right? There's not a lot of space for mom at that point either. But there's definitely a chance at that point. Oh, no. Yeah. I mean, I was 12.8 when I was born. There was a lot of complications with my birth. That's common with babies that are large birth babies, right? The smaller the baby has also some problems, but brachial plexus injuries occur there. So the baby's head is stretched away from the shoulder like the picture up there. The brachial plexus can get injured. Why can that happen? Well, you got to think about it. Babies' nerves aren't finished growing yet, and they're really kind of fine and easy to develop.
Is there like a visible sign, for the newborn, or?
There is, yeah. So a lot of times when a baby, and we're going to talk about what the different plexus injuries look like when babies. But a lot of times, shortly after birth, the arm will kind of contract up and in, and they don't use it. So baby will be doing its normal thing, kind of like crying and flailing around like they. And if you ever have worked in a NICU or seen a maternity ward, when babies start crying, they kind of move all of their limbs together to get attention. It's, pick me up, pick me up, pick me up for those who have moms, right?
Yeah, a lot of like shaking kind of.
Shaking, right? And so you'll see that arm is here and the other arm is moving. That's a good sign that they've got it. Or I've seen babies where when they're crying, their hand kind of looks like this because their C8T1 got damaged. So they've got almost an ulnar claw hand look going on.
Yeah, I see those actually.
Yeah, and that's an indication that the brachial plexus may have been stretched. And again, can it just go back to normal? Sure, it can, but doctors have to monitor that to make sure it's not an avulsion tear or something like that as well. What can happen for adults to cause brachial plexus injuries? Blunt force trauma is a big one. I've seen, we had one in the hospital back in Pennsylvania where a guy took a baseball bat to the neck. He was in a fight and the guy picked up a baseball bat and cracked him literally brought the baseball bat down on his neck and did a crush injury to the brachial plexus. Athletic injuries like football, quarterbacks are really at risk for that when they're back throwing the ball because that arm's stretched out, that brachial plexus is all stretched out. And as a defender, because I played defense, our point of attack is out here at the elbow. That's a pretty easy way to stretch it. Gunshot wounds, yep. Medical trauma, I've seen a couple of this where people have had spinal cord repairs where they've done anterior disc fusions or posterior disc fusions where they've injured the brachial plexus in the process. Cancer definitely seems to like the brachial plexus for some reason, and radiation treatment for cancer can then damage the nerves. So with babies, there are typically 4 types of brachial plexus injuries we deal with. And the most common is Erb's palsy. Erb's palsy is typically the upper portion of the brachial plexus, so C5, 6, 7. Typically has weakness in the muscles of the shoulder and biceps. And at that point, we're going to start physical therapy as early as 3 weeks.
Is that what they call the waiter's tip?
The what?
Waiter's tip?
I'm not familiar with that term.
Like, it's like their like hand is kind of like how does it, like flex?
Let me take a look. I'm gonna look that up because I'm not familiar with that. Waiter's tip deformity. Yep. So yes, evidently, I've just never heard that. Yeah. So what Erb's palsy can lead to that? Yes. How about that? Was not aware that even was a thing. I've never heard that term before.
I just watched too much YouTube videos.
Yeah, I've never heard that term before, but yeah, evidently that is a thing. So yes, that could lead to a waiter's tip. I doubt you're going to get a question on that on your boards. They're going to mainly refer to it as Erb's palsy, but yes. Now the good news for Erb's palsy is, for the most part, the ones that I've seen, it resolves, because usually I'm going to put mine in quotes, the pulling a baby and injuring that brachial plexus is a stretch, not a tear. So as long as they get physical therapy, we start working that arm, getting it back to kind of normal and getting baby kind of playing, roll and stuff like that, we can get them back to normal. But if it's a definite, tear, you should call Sokolov Love at 800. No, I'm just joking. I'm not going to do stuff like that. But there are all kinds of television commercials talking about, did your baby get injured during birth? Contact Sokolov Love at... Thanks. We're going to sue for anything, won't we? So Erb's palsy is kind of upper. Klumpke's almost never occurs in babies, right? But it sometimes does. It's lower root, so it's C8T1. So again, more of ulnar nerve kind of root. I've seen more of Klumpke's occurring in adults than I've seen it occurring in children. But it can lead to some problems with movement of the hands, specifically like abduction and adduction of the hands, as well as kind of those last 2 fingers where they get a claw hand developing, right? Or benediction hand. Total plexus involvement. There's about 20 to 30% of brachial injuries. At this point, this is where the brachial plexus is stretched the whole thing. And these children will look very, 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 very specific, because they will have their arm kind of retracted up almost like they're a stroke. At that point, the body's just pulling in because the arm's not being used. It's going to put it basically into almost a decorticate posturing with that arm, because if it's laying out here, it's likely to get pinched or trapped or something like that. So everything will kind of contract up and in, and they will stop using that arm, period. And looking at that question that Clarice asked, typically, they're saying that presentation of Erb's is where the arm's externally rotated and kind of out to the side. Yeah, but this one I definitely see the arm kind of contracts up and in. And then Horner's is probably the one I've seen the most, even though it says it's 10 to 20% of injuries. This is T4 to T2 to T4, so this is a little bit further down. And a lot of times this is a severe tear so bad that not only did it pull the brachial plexus, but it pulled lower down than the brachial plexus. So T2 to T4 is pretty low. I see these in a lot of cases where the doctor had to grab a hold of the baby awkwardly with forceps to pull them out, when they probably should have been, instead of a normal birth, the breech birth is really complex. They probably should have been a cesarean at that point, but the doctor decides he knows best, and he's just going to grab a hold of the baby with a pair of tongs and try to yank them out like a hot dog out of a grill. I've just seen this mainly because, again, I work in special needs peds, so I see a lot more of the real true severe injuries. And these patients, that when they have the Horner syndrome, you definitely can tell the main symptom that they get is one of their eyelids kind of just droops down and never lifts up. That's the one that the ptosis is kind of the one I see. If I'm looking at these, the 2 I'm studying are Erb's and total arm. So I understand those the best. Herbs is probably the one they ask you the most about when you're talking about brachial plexus injuries. So let's stem from there right into hand injuries, because this is the one that somebody emailed me. They were freaking out. They started looking at hand injuries and went, I don't understand any of these, Mr. McKeever. I'm not getting it. So Mr. McKeever has made one simple chart for you. You're welcome. So this is pretty much all the hand injuries you might get a question on your boards. So carpal tunnel syndrome, median nerve damage, right? First 3 fingers, and you'll get thenar eminence wasting in the later stage. And I did consult a hand therapist about this just to make sure that these were right, because I'm not a hand therapist. So I wanted to make sure I consulted somebody that actually knew what they were talking about. Decurvains is inflammation of the extensor pollicis brevis and the abductor pollicis longus sheath of the first dorsal compartment. So a lot of times these patients, if you have them hold their thumb like this and squeeze, they're like, yeah, that hurts. For those of you that play video games, if you do that and you have pain, you have a little bit of decurvains going on. I get that, especially if I've played for long periods of time. And if I do that, I'm like, oh my God, that's all flamed up. Because of the way the controller set, your thumb's kind of in this position, and that really kind of works those exterior muscles of the thumb. A Colles fracture is a posterior dislocation or fracture of the distal radius and ulna. There we go. Smith's is often called a reverse Colles. It's an anterior dislocation or fracture of the distal radius or ulna. A boxer's fracture is exactly like it sounds. Boxer's fracture is when somebody goes to punch something and misses with the 2 knuckles you're supposed to hit with and hits with the pinky, right? I had this once when I was practicing for my martial arts. I was practicing on one of those, a heavy bag that moved, and when I hit it the first time, it was good, and then it moved back, and I misjudged the distance, and I came in. I didn't fracture, but man, I just smashed that baby knuckle enough that I wasn't able to use my hand for a couple of days. Scaphoids are our fascias, almost fractured in a fallen outstretched hands. It goes hand in hand. See what I did? See what I did there? Goes hand in hand with a Colles fracture. So you can scaphoid fracture and drive it back to fracture the distal end of the radius. Dupuytren's contracture, we're seeing a lot on this only because there's a lot of television commercials for this now. Dupuytren's is typically 4th and 5th digit contractures at the MCP PIP, but it can be any digit. So understand Dupuytren's contracture is where the actual stuff, the actual tendons and that start contracting up and you kind of contract up. It looks a lot like a claw hand or a benediction hand deformity, but typically when you have those, it's median nerve damage, whereas Dupuytren's is actually soft tissue contraction. Claw hand, 4th and 5th nerve, right? And when you really get a claw hand or an ulnar nerve damage, this outside, the hypothenar eminence wastes away really quick. So benediction hand is seen when you make a fist. If you try to make a fist, the 4th and 5th digits move, but the 2nd and 3rd do not. This is benediction hand here, right? Ape hand is a reversal of claw hand, so it's a contraction of the first, second digits. Can be connected to benediction hand, meaning wasting, you can't use your thenar muscles. A Boutonniere's deformity is a central tendon extensor hood rupture. That's a big word. That basically means a Boutonniere's deformity ends up in MCP extension. So MCP here, right? So my MCP ends up extended, right? My PIP, my proximal flexes, and my DIP extends. So I look like this. Let me turn towards the camera. That is a Boutonniere's deformity. So what happens is I get an extensor tendon rupture out here. So now my finger can't extend. So they constantly are stuck in that kind of format there. They have to go see physical therapy. A lot of times they're going to have to go in and do surgery and repair that tendon rupture. A swan neck deformity is a little different than a Boutonniere's. So in this one, so if this was a Boutonniere's, A swan neck, we get MCP flexion, so I'm stuck in flexion, right? I get PIP flexion, so my proximal's there, and my DIP looks like that. So I end up kind of something like this, where it moves in, but that DIP is kind of extended way back. Mallet finger is the easiest one to kind of know. It's ruptures at the DIP. And mallet finger is where you reach in for something and you smash your fingers like that, and they go back and bend back. So you get a rupture of the tendons at the DIP, and you actually lose motion out at those DIPs. Gamekeeper's thumb, skier's thumb, breakdancer's thumb, they're all the same. It's a sprain or rupture of the ulnar collateral ligament. So the ulnar side of the MCP of the first finger. Trigger finger is a tendinous inflammation. So trigger finger is a finger that kind of is bent down like this. But what you can do is you can snap it straight, meaning it'll pop back. So there's the main difference. The main thing that people get confused with, especially when they get in hand therapy, is, well, where is it? Decor veins and trigger finger look a lot alike in the way they present. But with Dupuytren's, you cannot stretch those fingers back out. They are locked in place. With trigger finger, if you pull back, the finger snaps back. And you can actually get it to straighten out, right? Because it's more of inflammation, tendon inflammation, versus an actual adhesion in that hand. So I try to put this down as just an easy look at this. And then I think I did, there we go, a couple pictures for you guys, right? So here we have carpal tunnel syndrome up in this corner here. This is kind of decor veins. Here we have some beautiful fracture pictures. Look at that fracture. There's mallet finger. You see how that finger kind of goes out and just hooks down. And it can actually get stuck like this. And this patient will be splinted usually for 4 to 8 weeks. Another fracture, yay. There's our boxer fracture where we fracture that outside of the hand. Scaphoid fractures are really super painful. I actually had one of those in the martial arts and I never want to have it. Dupuytren's, you can see the fascia binding down there. All right, so we got extension, flexion, extension. Which one is that again? Extension, flexion, extension. Okay, booties. Yes, it's the booty, because the booty stuck out. That's the way I actually remembered it. Right, that's a Boutonniere's contraction versus a swan neck, which is this one here. I don't remember what this picture was supposed to show. They're just waving at you. I don't remember. Gamekeeper's thumb, again, is going to occur kind of in here, right? Or skier's thumb, that's where the pole kind of gets stuck and yanks that thumb backwards. And here we have ape hand or a benediction hand, depending upon what doc you're looking at. This one's probably more benediction because of the position of the thumb. The pictures are great, but the main thing you need to know for your boards is this. So the next question becomes that I usually, when I go over this is, yeah, Mr. McKeever, there's a lot there. What do I, how much, what's going to go on? Review all of them. It seems to be becoming more common to get more questions on hand injuries. I don't know why. Maybe it's because we're starting to treat them more frequently. And I'll admit, I've seen a lot more hand injuries when I was in the outpatient clinic than I've ever seen. I think because we're actually starting to see television commercials normalizing it to have hand injuries and go see therapy for it. But that was it for the PowerPoint. Again, the PowerPoint is posted. Were there any other questions of stuff you encountered that you were worried about that, you know, that's concerning you right now? I want to get out my little clipboard so I can write down if there's stuff I have to cover for the next time. Was there anything specific? Because I think there's going to be a class with Dr. Avreskin and Dr. Sokel coming up, if I remember correctly. Right? Isn't there something coming up with them? I don't remember when that was. Yeah, there it is on the 10th, right? Thursday, yeah. Was there anything specific you wanted me to pass along for them to cover for you guys? I think they're doing, if I remember correctly, they're doing musculoskeletal. Yeah, they're doing musculoskeletal and reflex review on that day. Is there anything you'd like me to pass along for them to review for you guys? Is there anything I can help you with? Again, if you need extra time with me, please just schedule it. I'm open to always meet with you guys. You can ask Clarice. I respond pretty quickly, wouldn't you say, Clarice, when you text me? I don't think, sometimes it takes me a little bit longer if I'm like running or something like that. I'm not going to stop running to answer your question.
Yeah, you do.
Right? So I'm always available for you guys at this point. So yeah, Thursday, it looks like Thursday at what time was that? I think it was, I just looked at the calendar. It's Thursday at, Thursday at 1 is Dr. Sokel doing pathophys, it looks like. And Thursday at 2, Dr. Ruskin is doing some musculoskeletal type stuff. And Dr. Ruskin said, if you can, please, by Tuesday, send her anything you would like her to review for you. Because that way she can kind of build stuff up. If you don't send it to her, send it to me and I'll send it over to her. I'll still be there Thursday for that, but she's definitely going to be handling a lot. Wait, no, I won't be there because I teach that time. So I will be not available that time because I teach the other class at that time. I think it is both. Doesn't say, oh no, it says via Zoom. I'm sorry, it says it's via Zoom. I'd look, because I'm going to be teaching at that point. So I'm sure if you want to come in, I'm sure Dr. O'Neill wouldn't hesitate to let you guys come in. I'm going to be teaching virtually, so it's not like I'll be on campus. I've got the other group right now in Kines and Therex, and they're terrified of me because some of the feedback I got, and I appreciate a lot of the feedback I got from you guys in Kines and Therex, I have integrated and changed some of the stuff I'm teaching. So I really you guys don't know how much I appreciate when you guys give me valid feedback. You know, when Justin sent me that feedback on that class, it was like, you suck as a teacher. I took it really personally and worked on, I'm just joking, Justin, you didn't say that. I do really appreciate any feedback I get to try to help you guys out because it makes me a better teacher in the long run. Can we go over complete 7? So C7. Yeah, I'll save that for me. They're not going to be able to cover that, but I can definitely cover that.
For me, it's all about just it's just all about the patho and like muscle.
Right, and that's what Dr. Sokel is going to cover a good bit of that. So if you have specifically some patho you want to cover, please hit her.
Anything.
Yeah, anything. I like that. We'll come up with a couple good topics for her to cover, please.
Okay.
Like come up with a couple that are really hitting you. Like maybe if it's something like
mostly pharmacology.
What'd you say?
Mostly pharmacology, like.
And pharma will probably pass a little bit back to me, but she can definitely hit some of it as well because she's got it.
No, especially for like just the big ones, like for Alzheimer or like Parkinson's, because
Okay.
I always get them confused.
Well, what I can do is I think I've got another one scheduled for next Friday as well. I can add pharm to that and cover, like, go over the specific drugs for pharm. That's not a problem.
Oh, okay.
So, Sukana, you said C7 tetraplegia complete versus L3 paraplegia complete. That's actually really a good question. So, are you talking about you're not understanding what the difference is between the two or how they both could be complete? So, let's break that down real quick, just because that one actually I can cover pretty simple. That one's not even one I have to do a write up a review on and draw it out and stuff like that. But let me bring up a whiteboard really quick. It's just because that way I have something to draw on. A drawer on. There we go. I got a whiteboard.
Mr. McKeever, it's like because they ask you like is it going to be independent for the wheelchair transfer?
Yep.
It kind of confuses me a little.
That's what I'm going to talk about real quick. So
you.
Let's break that down first of all. A complete injury means what? What is, when you see a spinal cord that says it is a complete injury, what does that mean?
Cannot walk at all.
Okay, no motor or sensory. Good. The main important is no bowel and bladder. Complete means you have no function of the lower sacral segments, S4, S5. That also usually means anything below the injury level. So if she had C7 and she had L3, that means if I had a C7 injury, most of the stuff below C7, so, you know, T1, T12, all the way down to L3, there's no function. If it's an L3 complete, that means everything below L3 would be non-functional, which would include this S4, S5. So the complete is just telling you that they've got no bowel and bladder function, right? Versus an incomplete with spinal cords means they have some S4, S5 function. That would also be a partial preservation, meaning that, that's an A, meaning they've got some function below their injury level. So if I was a C7, I could be injured up here at C7, but still have bowel and bladder if for whatever reason the primary injury is occurring up here and I'm still having some stuff down below that works. So that's the part of that. So when you're looking at levels, they're going to ask you which of these patients is appropriate for transfers, what type of transfers could they do? What you have to go back to is your dermatomes and your myotomes. That's the main thing. Again, I'm gonna preach. If you know your dermatomes and your myotomes, you can answer most of these spinal cord injury questions. If I have a C7, that means that is my last level that is fully functional. So let's think about that. If that's my last level that's fully functional, what motions do I have in the upper body?
Shoulder.
Okay, I've got most of my shoulder stuff. Good. Most of my shoulder stuff. So I got most of the ups, backs, downs, right? I've got most of that. Do I have my biceps?
Yeah.
Yeah, biceps because they're C5, C6-ish. I have some hand motions, right? But some hand motions are C8, T1. So I've lost some of them. But I've got some of my wrists, remember, because when we talked about C5, C6, we also had revving the bike, right? So I've got some wrist extension. What about scapular depression? So dealing with that type of motion, do I have that? Or triceps extension?
Yeah.
What level is triceps?
C7.
What's that?
C7.
C7, C8, so you have some. You may not have full triceps, right?
Yeah.
So what would be the appropriate way for this patient to get out of a wheelchair?
Sliding board.
Good. Sliding board. Is that patient going to be able to stand up and transfer?
No.
No. That patient will never stand up and transfer, ever. Right? Does that mean we can't transfer them that way? Sure, we can, right? We can physically pick them up and move them over, but that is not functional. Now let's change this up. I'm going to go down to L3 in a second, but let's change this up here a second. So let me erase this. So now...
Hold up, I just realized something.
Yep.
Okay. So when you say like nerve injury on like C7, so it means C7 down are like complete useless?
Yeah, so C6, C5, or I'm sorry, C...
And then C6, like C5, C4 are like okay still.
Those are okay, yep.
Oh,
Exactly.
wow. Okay, that was easy. That took me a long time.
Okay, that's okay. If it hits you, it hits you. I don't care when it hits you, Clarice, right? So it's saying that everything up here is good. Everything down here is bad, right?
Yeah, like total, like no motor, no sensory, but anything.
Yep.
Okay, so
Now-
so if I say like nerve injury to like L3, so anything that's like L2, L1 are still good, and then L3 down are bad.
Yeah. So
Oh my
well, L3 is still good. Remember, L3, if it says L3 complete, that means L3 is still good. L4 would be bad.
Oh, wait.
L5 would be
When
bad.
you say L3 complete, the L3 is still okay?
Yes, because remember when I say like complete, if I said a complete T10, This is the nerve injury level. What that means is that's the last area, or the neurological level. Sorry, I didn't call it nerve injury. I call it neurological level. That is my neurological level. That means that is the last area that I have full sensory and motor on both sides.
And then incomplete is kind of like diminish.
Could be diminished, right? So I'm going to hit that in a second. Bilat, right? So if I say T10, that means at T10, I have full motor and sensory. If I go below that and go T11, I may still have some sensory or I may still have some motor, but I don't have full. Even in a complete, I could have a little bit of function down there. I could have a zone of partial preservation, but it's not full. I don't have anything that I can really functionally use. T10 is my last functional level. The complete versus incomplete is just this up here. It has to deal with the bowel and bladder. Other than that, don't totally worry about that. Just know that complete versus incomplete is just telling you, does their bowel and bladder work at all? Right? If my bowel and bladder doesn't work, how am I going to avoid my bowel and bladder? How am I going to empty my poop and my pee?
Diaper.
Could be brief, but could be catheter. Good, right? It could be that it just empties automatically, like we have no control over it, right? We have an areflexive bladder, meaning it just fills up and then dumps. Or actually, it's a reflexive bladder. I'm sorry. The bladder fills up and it just dumps and you have no control over it. Or it could be areflexive, that it completely fills up, distends, and you actually have to catheterize it to empty it, right? Versus incomplete. Incomplete could mean my bladder is working, but my bowel is not. Or my bowel is not, but my bladder is working, right? So
do they usually use colostomy bag too?
do they usually have what?
Colostomy, is that the one, right?
You could. We theoretically could do a colostomy bag on it. I mean, the only reason they're really going to do colostomy is if there's some involvement with the lower intestine as well, which can happen. I've seen a lot of patients that get spinal cord injuries that get kinks in their lower intestine because they spend a lot of time on their back or something like that. So they'll end up in a colostomy eventually.
But mostly it's just diaper catheter.
It's brief. Yep. So I'm going to change this up. We talked about C7. Let me erase this real quick. So now.
Let's verify this because it's like still getting confused. All right. So when you say C7 complete.
Let's do one. I think this will clear up your confusion. How about that? So let's say we have a C4 complete injury. Okay. So that means that's C4, right? That's pretty high up. And that's probably going to be a whiplash injury, right? Or a spinal cord injury in a car accident. I've got a C4 complete. Does this patient have bowel and bladder function? No, right? Because the complete tells us no bowel and bladder. At what level is our last fully functional spinal cord level? So both since C4, good. Can the patient breathe on their own? Yes, because remember the old phrase C4 or breathe no more. So that means they've got diaphragm. Okay. So C4 is working, C3 is working, C2 is working, C1 is working, and then your cranial nerves are working. C5, C6, all the way down to S5. These are nixed. They're out. Right? We cannot trust them to work normally. Right? Now, you may have some weird thing where maybe at T4 on your nipple line, you still have some sensation for whatever weird reason. Like I had one guy that, funny enough, he had T10 sensation. So his belly button, like when we grabbed a hold of him to move him, he got ticklish when he grabbed his belly button, but he had no sensation anywhere else, and it was like a C7 injury. It was just this weird area where, like, every time you touched him, he'd giggle because he had sensation in that area only. Sometimes that weird crap happens, and we have no reason why or the rhyme or reason why it happens, but none of his core muscles worked, so they were completely gone. If we have this C4 complete, how are they going to transfer?
Wheelchair?
Well, we're still going to move them around in a wheelchair, but how are they going to transfer from? Yeah, times 2 is possible, right? But more importantly than dependent, what are we going to teach the family to use? Because we don't. What's that?
Sliding board still.
Okay, sliding board. We teach the family?
Hoyer lift.
Hoyer lift. Yeah, this is a lift.
Oh, Hoyer lift.
Right? Because let's think about what muscles at C4 do I have? Pretty much what muscles are the only muscles I have left? Yeah, like upper shoulder muscles, right? So I may have some traps, right? I have some deltoids, little bits, but I don't have much else, right? So my arms are pretty much useless to me. We know the legs are useless, right? So that patient is going to be a lift transfer, right? And whether that's a Hoyer lift or a dependent lift, right? We could still transfer them with the sliding board, but they're not going to help us at all because they have no ability to control their arms. They can't. There's no way they can use this if they've got no finger use or hand use. What type of wheelchair would this be? Sip and puff, good, right? This is going to be that wheelchair with that little tube that comes around, and because they don't have any motion of the hands. They can't use a motorized wheelchair, right? Or they could have a caregiver, right? It could be that maybe, Sakana is taking care of Jervin. It's pretty much the only time we're going to use a wheelchair, unless it's ALS, Sakana, because a lot of times ALS will end up in a sip and puff wheelchair as well, because again, they lose. Remember, ALS is distal to proximal, so they're going to lose their hands first. And eventually, honestly, with ALS, we usually move to an eye wheelchair, which is actually really cool. I mean, the eye tracking wheelchairs are pretty neat. Like the person looks up, the wheelchair goes forward. The person looks down, the wheelchair goes backwards, left, right. Some pretty advanced stuff we got going on. Does that help make sense of at least the level? Like understanding that if it's a C4, that's the last group of muscles we have that work.
Yep.
Okay, thank you. Okay. So now let's look at that L3 patient real quick. So let me erase here. I actually like the whiteboard. I wish I had my tablet's not charged because, well, I used it on the airplane. I'll have you guys know, I really don't like that new HBO Max app because for whatever reason, even if you download a movie to it, you still have to have Wi-Fi connection. That completely defeats the point of the HBO. I'm sorry. These are the things that Mr. McKeever gripes about. So now we have an L3 patient. And let's change it. Let's make him an L3 incomplete. As far as transfer goes, does complete versus incomplete matter at all? No, right? Complete versus incomplete just tells us about their bowel and bladder. I don't care about their bowel and bladder getting them up out of a chair, right? The only thing I care about mainly is what muscles work for me. So I know L4 and down are gone, right? Versus L2 and up, I have. So do I have trunk control? Yeah, right? Trunk roll, all my T's are good. So I've got good upright posture, right? Do I have some hip motion with L3? Oh God, now I get a trick question.
Yeah.
Think. Yeah, L1, L2 is most of your hip motion. Good, right? I may be missing some of the posterior hip, but I have most of my hip motions, right? How about knee control?
Jerky?
What's that?
Jerky?
Maybe jerky or spastic. I'm not going to have much, right? At L3, I'm going to have just some basic knee control. But could I possibly stand up and transfer?
Using your arm?
There we go. Good. Using my arms, right? I can have something up here, right? Like one of those triangles where I pull myself up. I could use braces in my knees. I could get this patient standing, right? They may not have the best knee control, and I may need an AFO or a KAFO that holds my ankles and my knees in place. But yeah, I can get this patient up and standing.
Or back to being a baby where you're like using the furniture.
Yeah, maybe right. Maybe using the furniture. Right? I can sit on the furniture and be pretty okay. Right? Because when I got core control, that's the main thing. Maybe getting in and out of the chair might be a little bit like if I had a lazy boy recliner or something, that might take a little bit of help. But if I've got one of those pull triangles, I can do most of my activities. So I'm still probably teaching an L3 sliding board transfers because again, sliding board is probably the safest, right? Because again, if I try to stand up, I don't have full knee control. So if I'm by myself, we could do a pivot transfer. Exactly, Sukana, right? We, with them, could definitely, or family, could do a pivot transfer with them. Right? Because they've got core control. They're not a ton of work for us. Right? I'm still going to teach them sliding board because sliding board makes them independent. Doesn't it? Because man, if I've got all my upper body, I can easily scoot my bottom along that sliding board like crazy and get from chair to chair and stuff like that. So for sure, I'm going to teach him sliding board for independence. But when I'm working with family, I want him to get upright. So I'm going to teach them also pivot transfers. Does that help clear that up maybe a little bit for you? Cool. See, occasionally I actually am useful. It's very rare, but occasionally. That one's an easy one for me to cover just because that's just covering the basics of spinal cords. But again, with spinal cord injuries, when you look at it, you go L4. What I would do if I'm getting a spinal cord injury, I'm looking go L4. It says complete. Don't care about complete unless it's asking me about bowel and bladder later. Don't care about the complete. L4. Okay, so I have L4, I have L3, I have L2, I have L1. I'm thinking about what muscles I have up there. And I'm going, okay, L5, what did I lose? L6. That's it, Dylan. Complete versus incomplete is bowel and bladder. Yeah, it is too easy, right? And why they throw that in there is because you see complete and it starts throwing your brain off. Right, because you're going, well, wait, it's L4 complete. They've lost all of L4, right? And in reality, complete versus incomplete just means bowel or bladder. That's it. You're worried about that number, L4. I got L4, right? Like if I'm an L5 injury, I've gotten most of my movements. I probably can eventually get to walking. Really, I mean, if you lose S1, S2, S3, S4, I mean, yeah, you lose some of the foot motion, but for the most part, I can walk. So don't totally freak out when you see that type of stuff. The main thing, again, you see incomplete, complete, look to see if it's asking you questions about bowel and bladder, right? So if it says, you know, your patient is an L4 or L5 complete, how would a question word about that? It would say something like, how is your patient likely to void their bladder? You're going to probably go down and look for catheter. Because that's probably what the answer is going to be down there. That help a little bit, Clarice and Sukana? I saw Sukana said yes. How about you, Clarice?
Yeah, well, much better. I realize it.
So what I'll do is I'll put on farm definitely for me. I can hit a little bit of that on, I think I have scheduled one on Friday if I remember correctly. But definitely hit up Dr. Sokel and Dr. Reskin. Give at least Dr. Sokel, okay, that is, you know what, Hector? That's a great one for Dr. Reskin. For when she does her review, ask her if she can cover that. That's a great musculoskeletal one for her. That's an easy one for her to hit. Spondylosis, spondylolysis, spondylolisthesis. Yeah, definitely give her that one. She'll appreciate that one. She can cover pretty quick. And the main idea is just where the injury. It's honestly just the way the spine goes. But she can cover that quick. That's a definite. She actually likes that one, so I know she'll hit that one. And if she doesn't cover it good enough or not, I don't say she wouldn't cover it good enough. If you need additional help with that, I can also go over it as well, but give her a chance to cover that one because that one's a good one for her. Because she really loves the spine. I don't know if you noticed that, but like she really loves hands and she really loves the spine. If you couldn't tell that when she was making you do all those spinal exercises and stuff like that. I think she was McKenzie or is McKenzie certified. I can't remember. I think she is, now that I think about it. All right, anything else? Not, I'm going to stop recording a while.